So today is our State Technical Assistance webinar, and we'll be here for 1 hour together from 1 to 2 p.m. Eastern, or whatever your time zone is. As a reminder, this project is sponsored by the Health Resources and Services Administration, or HRSA, as part of a cooperative agreement with HRSA. The information or content and conclusions are those of the author and should not be construed as the official position or policy, nor any endorsements be inferred by HRSA, HHS, or the U.S. government. Some of our technical tips today, I'm sure many of you have been with us before, but as a reminder, audio is only broadcast through the phone line, so please please mute your computer speakers so we don't get an echo. To be heard and to hear, please call into our phone line. As you can see there, our phone lines are open, so please mute yourself. Please unmute yourself during the Q&A, and you can just press ## to do that, and then *# will remute you. There is a download pod and where it says web links above, where you can and STAW files where you can get some links and download any resources that we mentioned here today. Please use the chat pod. You can see it sometimes will move, sometimes it will be to your left and sometimes to the bottom, but please feel free to use that to communicate, ask questions, or let us know if you have any troubles during the webinar. As a reminder, this session is being recorded. So I would like to introduce our presenters. I'm Erin Ficker. I'm with the CSLC and the Children's Safety Network. I am the lead for our SUID, or Sudden Unexpected Infant Death Prevention team, as well as other tasks as assigned. And I'm joined today, I'm very excited to be joined today by our guest speakers from Kentucky, and these two wonderful folks are the team leads for the CSLC, or the Child Safety Learning Collaborative team. We have Dr. Howard with us today, and Dr. Howard is the Chief of Pediatric Forensic Medicine at the University of Kentucky Healthcare. She's a specialist in child abuse and has served as the co-lead for the Kentucky CSLC Suicide and Self-Harm team. Nicole Barber Culp is with us as well, also one of the co-leads of the Suicide and Self-Harm Prevention team through the CSLC, and has and works for the Kentucky Department of Public Health. And we are very lucky to have her with us as well, and to hear from them as we move through this webinar. The CSLC framework for quality improvement, just as a reminder, if you haven't seen this, the CSLC framework, we work with child safety expertise. We focus on leadership and management and systems improvement. And the work that we do in those three areas is focused on building the workforce, improving injury and violence, systems prevention, moving eventually towards our outcomes of having an impact on health and a decrease in child injury and violence. So today we're focusing on leadership and management. If you're interested in learning more about our framework, we do have a white paper on the framework, and you can learn more about that, finding that on our website. So I wanted to just focus a little bit today as we think about quality and process improvement, to keep in mind these 5 key principles of improvement, and they come from the improvement guide, and which is really a guiding text for us and for most people in quality improvement. So the first is that we know why we need to improve. So having an understanding of what the challenges and problems are that we need to address and the work that we need to improve. Secondly, having a feedback mechanism to tell you if the improvement is happening. And this is that really important data feedback loop. And we'll talk about that a lot as we go on, and the importance of that. Third, developing an effective change that will result in improvement. This is that evidence-based approach to ensuring that the work that we do will lead to an improvement, that we're focusing on the right change and the right change for the improvement that we're seeking. Our fourth principle, testing the change before attempting to implement. So important, and such a key tenet of improvement. Testing the change is those small tests of change that we do and often redo and redo until we get the change that we're looking for, refining as we go and changing as needed until we get that change. And knowing then, that's our fifth principle, right? Knowing when and how to make that change permanent. So we test until we know that it's ready to become a permanent change and a permanent improvement to our system. Those are our 5 principles of improvement, and I will keep referring back to those as we move through our webinar today. Quality improvement requires a team. There's just no doubt about it. And in large part, it goes back to those 5 principles. The reason we need a team is so that we can have multiple minds thinking about identifying those problems, helping to identify the solutions, someone to help monitor the data, and a team of people to be looking at that together. That group can then together test to change, look at those results, and determine if that change was an improvement. So those are really the tenets of why we need a team. If you'll notice, this org chart that I'm showing you here is a reflection of the Child Safety Learning Collaboratives model that we use for our state strategy teams that we recommend. So you'll see at the top there's a management sponsor, and often in the CSLC that person is the Title V lead in the state. And that would be the person that would sign off on your application and agree that you would engage in this work. But there may be someone else who serves as a management sponsor who might be slightly closer to the work. If that Title V leader can't be involved in a closer way, you might find that you have kind of a second or co-management sponsor that does that work. And we'll get into the roles that these folks play in a little bit. Down from that management sponsor, you'll see that we've put on the same level that team lead and data manager, really focusing on the key importance of data and leadership in this process and on the team. We also have then a more complete team that includes state-level partners, local partners, the population impacted by the change. And when I say that, I think about the people who will be implementing that change and the people who will be impacted by the change, right? So we might think about the workers who are implementing the change and the clients who will be impacted by it. It should be a part of that team. And then a subject matter expert, and that subject matter expert can be someone who focuses on the work or focuses on QI, or both. Often it's helpful to have a quality improvement expert as well as a subject matter expert on your team. So that's our quick overview of what your team, the folks your team might include, and I want to just break that down a little and move into, for each of these folks, what their role is on the team. So as we think about this, and in the CSLC model, again, this management sponsor may be that Title V leader, but it may be a shared role with someone else, and we'll share a little bit more about that as we go. But the management sponsor's role is really, there's someone at a high level, often an executive director or a division leader, Title V leadership, and they're able to give resources and support to the project. So they're really someone who's able to remove and reduce barriers. They're able to say, this is important, and to raise the profile of the project, communicate with other staff the importance of the project, and make it a priority within the agency. And they often can help you recruit team members if you maybe don't have the clout. Some of us don't always have the clout to get people to join us or to be as persuasive as maybe someone higher in the organization might be able to do. So they can often help recruit those team members. And it's really someone who should remain in contact with your team lead. So this is someone who you can come to as a team leader, you can come to with struggles or challenges, ask them to help you with any of these things, have them help you communicate with the staff, have them help you raise the profile of the project or recruit team members, and someone who you should just stay in regular contact with. So that's our management sponsor. And they may not be involved as much in the day-to-day work, and that's where our team lead comes in. And to be taking just a quick step back, both the management sponsor roles and the team lead roles are roles that have been researched fully by the Behavioral Health Center for Health Enhancement and Systems Studies at the University of Wisconsin at Madison. And they've done a lot of work around looking at what are the key things that makes a team successful, and then putting that into what are the roles of the team lead and the management sponsor. So these are not just great ideas that we have, but really come out of some specific and significant research done at the University of Wisconsin. So the team lead is someone who needs to either gain support or work together with that management sponsor to get the project rolling. They're going to be the person who assembles that change team, right? It brings those people together. Again, they may need some support from the management sponsor, but they're going to be the person who assembles that team. They're going to identify the problem or programs if needed. That problem may already be identified, or it may be something that the team lead identifies, again, often in combination with the management sponsor. They're going to work with the team to identify program changes needed, so they're really going to dig in with that team. They're going to also facilitate all that process. So this is someone who's going to have a lot of different skills, because they're also going to really be responsible for delegating work that's identified as necessary to implement the change. And this is where we go back to, you need a team. There's much to be done in these processes, and so to be able to delegate that work is important. So the team lead needs to be someone who can do that. And then oversees the measures, right? And again, being data focused. So going back to those key principles, making sure that we have a feedback mechanism, that team lead is really responsible for watching over that. So often this role may be shared, or it may be a role that one person is doing, but obviously this is a team leader because this can't be done alone. So we want to make sure that the team leader has the support of the management sponsor, has a great team underneath them, and then has the skills to do the work of leading the team. And a little bit later, we'll dive into some of those skills that are needed by the team leader. But before we do that, I'd really love to bring in our colleagues from Kentucky and hear a little bit about how the management sponsor and the team lead in Kentucky have worked together. So I'm going to turn it over to Dr. Howard.
Hi guys, yes, so as we talk about really the importance of establishing that strong...
Dr. Howard, are you
yes.
muted? I'm not hearing you.
Erin, I can hear Dr. Howard.
Okay. Can you guys hear me now?
Yep, loud and clear.
Okay. All right. Well, thank you guys. And so as we talk about the importance of establishing that really strong core unit, I wanted to talk about how our team here in Kentucky really started. And I think ours is a little of a unique partnership. I am not an employee of the Department of Public Health. I'm a physician at the University of Kentucky. And in my role at the University of Kentucky, I sit on the hospital child fatality team that reviews deaths. And in one particular month, we saw 3 suicides or attempted suicides in a pretty young age group, the 10 to 11 age group. And it really affected a lot of our team members. And it really started to raise our questions like, what is being done at a local level? What's going on in these communities? And knowing the child fatality review teams with Department of Public Health, after that meeting, I reached out to them, and it really started a partnership with myself and the Department of Public Health. And I became a consultant for them in child fatality review and injury prevention. And so I worked with Jan Bright, who's the manager of the Child and Family Health Improvement Branch. And we were in her office meeting one day and started talking about our plans moving forward and really what we wanted to see happen. And I think she had received an email from CSLC about a second cohort and how it would be nice to be able to utilize those national resources for QI and moving forward in our prevention strategies. And so we started to brainstorm about what we wanted to do moving forward, who we thought needed to be involved, and given Jan's role and knowing kind of where we were pulled in multiple directions, she thought that it would be beneficial to have Nicole come in and kind of help co-lead our team. And so I remember sitting in there pulling Nicole in, Nicole being a little like, what am I walking into? But luckily, Nicole agreed to co-lead this initiative. And so Nicole and I have served as the co-lead members, team leaders, and we meet on a regular basis every month, whether that's once or twice per month. And then we have a Kentucky-wide team meeting usually once a month. And so Jan stays in contact with us and what we're doing and how things are going, and she kind of helps take a lot of the work to get approved by Dr. Bada, who is our Director of Division of Maternal and Child Health. And so Dr. Bada will attend meetings, usually about quarterly, but stays in the loop via that kind of chain through Jan Bright. And so that's kind of how our team has developed. And then the first step that we really needed to determine is what was our focus going to be. And as I was sitting in a lot of the child fatality review team meetings, we would review all these suicides that were happening in our state and what was going on with them, and reading through those histories of all the adversities that these children were going through, it really hit close to home as a child abuse pediatrician. Because with child maltreatment being a lot of those adversities, it made me start to look at what were we really doing for these kids. Yes, I can diagnose child maltreatment, but if we're not helping the survivors of child maltreatment, then what is the point? And so it really made me passionate about suicide prevention. And you can move on to the next slide. And so as we started to meet, we started to develop our vision, and knowing that we wanted to focus on suicide prevention. But I think a lot of what we were seeing at CFR, a lot of it is anecdotal. We need to get really hardcore at the numbers. So we wanted to establish really a data-driven system to help us inform us on evidence-based strategies that could help us to decrease youth suicide attempts and the number of adolescent deaths by suicide. And given that zero suicide is a well-established prevention strategy that is evidence-based, that was our focus that our team decided to move forward with. And so I think now that we knew what our vision was going to be, that is where we were able to see kind of what other team members did we start to need to pull in. And so Jan was able to help with that with her contacts across the state. And then we will kind of talk through how additional team members were added as we progressed through our project. And I will turn it back to you, Erin.
Thank you so much. It's great to hear from a real-world example. I'm going to go ahead and really want to take a minute now to hear from you. So I'd like to ask you guys some reflection questions, and you can go ahead and type in to the text boxes right below the questions, and you'll see our first question is, how is your management sponsor and team lead working together? How's that going? And do you have a defined vision for your quality improvement work? So we heard from Dr. Howard about how they were working together, and we also heard a little bit about how their vision developed. So if you could share with us, and you can type in the chat, or you can also just go ahead and type or unmute yourself and speak up. We'd love to hear your voice as well. But how is that management sponsor and leadership team working together? And have you identified a vision, and can you share that with us? So just quickly to reflect. And if that hasn't happened yet for y'all, that's fine too. So that's a great, answer, which is to say that we're not working together very closely, or we haven't needed to work together as closely. So we're hearing from Missouri working fairly well, giving advice, enthusiastic, and attend some of our meetings and webinars. That's great. And that is really one of the things that you really hope for with a management sponsor, is that level of engagement, but often really difficult to attain. So anyone else on audio want to jump in and share their vision, the vision that you've developed for your quality improvement work? Anyone? Maybe someone from our Texas team or Wisconsin. We also have some teams from Georgia on the line who might have good experience with this. Feel free to just okay. Marissa, you can go ahead and unmute yourself if you'd like and just share with us your thoughts if you're able to, and that's *#. Can't think of a defined vision. Thank you so much for sharing that. And that's okay. Sometimes that's something that coalesces over the course of time and maybe not right in the front. We, as Kentucky reflects on this, something they're able to reflect on how that happened. And so that may not be something that jumps out right from the beginning. So I see some more folks typing, and we'll just wait one more minute. And if you have anything else to share, feel free to just unmute that line. And remember, if you're self-muted, so if you've muted your line yourself on your own end, you'll have to unmute it that way. So Marissa, you're meeting regularly to discuss plans and vision. That's wonderful. So glad to hear that you guys are developing those strong relationships and have that support of your management sponsor, which is just really helpful because they are the people who can take down barriers often. So great. Well, let's go ahead and move forward and start to look at some of those other folks who we work with on a regular basis on this team and who are key to the success of these projects. Oh, sorry about that. So the first one I want to get to is, remember, looking back at that org chart, this was on the same level with the team lead in our CSLC-focused org chart, because we think the data manager is such a key role and really engages in all of the 5 principles of improvement. They're going to be the folks who access data. They have access to data. They can get it for you and bring it to meetings, bring it to you directly and to the management sponsor to help identify the problem, using that data to identify the problem. So they're going to be key in that principle of understanding. Ultimately, they're also going to help you to identify the measures that will answer the question, how will we know if this change is an improvement? So they'll help you identify what is it that you're going to measure in your change. So for each of those changes you make in the test, they're going to help identify what's the measure, how are you going to measure it, and how will you know if it's an improvement. So that's a key role and a key important part of our principles of improvement. They also provide support in data measurement and selection, again, so kind of helping you understand how to measure. They're also really going to help the rest of the team to understand that data. So as a team lead, we often emphasize that it's important for that person to be comfortable with data, but some of our team members may not be, and so the data manager can really help play a role of helping people feel more comfortable with data and translating it if needed. And they'll track the data too, so there's someone who can help to keep track of data as you're moving along. So that's the key role of our data managers. And like I said, essential in all of the 5 principles of improvement. I want to move on to our subject matter expert, and also someone who's key in most of those 5, if not all of those 5 principles. So the subject matter expert is someone who's going to provide insight on your topic. If you're working in, for example, motor vehicle traffic safety, this is someone who can provide insight on that topic, maybe someone in the state or at the local level, or someone who works for the university, an organization that's done research on this topic. This is someone who can provide insight to an entire team if they may not be as familiar with the topic as everyone, as the subject matter expert. They're going to provide guidance on changes to tests. So they may have some insight on what are some evidence-based changes you can make, what are some approaches that you can use. They may bring that expertise. They're also going to assist in understanding those test results. So they can be the one that helps you think about, after you've looked at that data, to really decide, is it an improvement? And look at all of the work that happened, the test results, the data, the processes, and say, was that an improvement? And understand those results as you go through those multiple small tests of change. So also that subject matter expert is going to help support the use of multiple QI tools. So hopefully this person often can be two people. Like I mentioned before, we can have someone who's an expert in the subject that we're working on, whether it's motor vehicle traffic safety, sudden unexpected infant death, or another child safety topic. But maybe you also have a quality improvement person who's on that team who's helping you manage those quality improvement tools and use those tools as you move through. That may be someone that you utilize through the CSLC, or it may be an internal person in your organization who does QI. So they have an important role on your team. And I really am interested to hear how Kentucky continued to grow their team with the addition of data managers and a subject matter expert. So I'm going to turn it back over and to Nicole this time.
Thanks so much, Erin. Yeah, so in growing our team, we knew that our next step was to focus on the data and what we were hearing from our child fatality review team, which Dr. Howard spoke of earlier, and then also to bring in our subject matter experts. So we, fortunately, at the Department for Health, we have a wonderful epi department that's within our maternal and child health program. So we have about 3 to 4 EPIs who are actually dedicated to working on some of the data for our program. So we knew that we needed to reach out to Beth Lynn to really connect all of the data pieces together for us. And the wonderful thing about Beth Lynn is that she has connections to other data resources in the state of Kentucky. So she was able to ask one of our state partners to access both the suicide rates for the adolescent health population and also self-harm ED visits. So once she connected with that partner, she really was able to give us such a wonderful visual of what our rates look like in the state of Kentucky for both of those areas. Really able to explain it to our team really well, and then we knew, okay, so we can't address this throughout the whole state as our small team, but our goal was to really focus on those areas who had that higher trend in both suicide and self-harm. So we were able to use her data and those visuals to kind of pinpoint next steps as far as where to go. Beth Lynn is involved in all of our meetings, so she is there for every meeting and every call that we have, and actually has done some of our presentations on this data to partners as well. So when we're explaining this work, she's able to actually bring in the data to provide that support to the why and how of this work that we're doing in the collaborative. So looking at that, we also knew that we had to have a subject matter expert on board. And so we brought in Beck Whipple, who is actually with our behavioral health, Department for Behavioral Health at the state level. And Beck is kind of newer to the role. He was at that point newer to the role of the State Suicide Prevention Coordinator, but he had already been working with me on some other maternal and child health projects and also working with our child fatality review team. So we knew that he was kind of the go-to for next steps with this work. So once Beth Lynn had all the data and visuals, Beck was actually able to give that supporting supplemental guidance to her data and say, hey, well, these are some other trends that are going on. There's a coalition that is located in this area, or a community mental health center that we can partner with to really progress this work. So when we tied in both the data that Beth Lynn had plus the knowledge of Beck, we were really able to get a hold of where we wanted to go with our work in terms of target populations, and then who our partners also needed to be. So it really just gave us those that's really where our success was, really, in getting all this work together, was taking those next steps, having those conversations, looking at the data, and then having Beck give that supplemental support, this conversation to our discussions as a team. Beck is on all of our calls, and he also participates in the collaborative work as well for each of the specific calls that we do within this work. But both are very active in our team and are there for us to reach out to at any point in time that we either need more guidance, or if they find out other things are going on that might help the success of our work, whether it's training opportunities for us as a team to help us better understand zero suicide, or giving us the opportunity to learn more about zero suicide. He's really great at sharing those learning opportunities with us to help us learn as a team, and also for our partners to learn as well. And back to you.
Thank you so much. And I see that Dr. Howard has said in the chat that she'd not been familiar with zero suicide, and having that subject matter expert on board was incredibly important. And I see some other great conversations happening in the chat as Jenny has posed some questions. So please feel free to continue to read that as we go, and we'll look back on that when we get to questions and answers if there's anything else. So not to be diminished, but by putting them last, but the role of other team members here is really essential. So we've talked about kind of the two upper layers of that organization chart, but when we get to that bottom layer, and it is, again, not to be diminished, we look at state-level partners, local-level partners, the population impacted, and that subject matter expert, which we just talked about. But these team members are also essential to the work. And again, I can't say it enough that it takes a team to do this work. So those team members are going to include multiple sectors and populations. They're going to give you insight that maybe you, from your perspective, don't have, right? So they're going to help see a more complete picture. So the more people you can get around that table who look at the problem from different angles, the more you're going to have a full idea of what's happening. They can also take an active role in making the change. So often these are folks who can really help move the change along. If they're at the local level and you're working at the local level, or you're doing one of your small tests at that local level, they're going to be the people that help, right? Or if they can help to remove some barriers to get to the folks who you need to be working with. They should be involved in key decision points throughout the project. So they should be involved at every step in engaging in those decisions as you move through. Was this an improvement? What does the data look like? What should we do next? What's our next change? Because often these team members are, like I said before, members of the impacted population, and whether that's those who are implementing the work or those who are being served by the work. So for example, if we're talking about making changes in how we do work in a maternity ward to educate folks on safe sleep, it's that nursing staff who are asking to make changes. Make sure they're at the table. Parents who have new babies, who've been through this experience recently, can help also identify some of those issues. So making sure that those state and local level partners also help give you access to hospitals. Are they someone who can help do that? So as you can see, Jenny's written in the chat a question, which is, what other team members do you have? And do you encourage members of the population, do you engage members of the population you serve and community-based partners? So if you want to, feel free to answer that question in the chat. These team members are essential at every step of the way. Some may be more involved at times than others. So some may be more involved at the beginning of the process and some in the end, or some in the middle while you're doing those small tests of change, but they are essential throughout the process. And the research from the University of Wisconsin has really shown that it's these team members and these specific roles that they play that help to lead to the success of a project. I'd love to hear how Kentucky continued to grow their team. And I'm going to ask Nicole to pick up from here and tell us a little bit about how they continue to grow their team.
Yeah, so we expanded this. I think one beautiful thing about the partnership that we have with Dr. Howard is that she obviously has so much clinical expertise on her side that is working every day with patients. And she's able to provide that support and real life experience of what's actually happening in the clinical setting out there. And then, we have public health, we have our other state partners, and I kind of spoke to this earlier when I was talking about BEC being able to connect us to some of those community centers in regional areas. So we'll start with Jennifer, who I think is actually on the call today. So thanks so much, Jennifer, for being on. But Jennifer Perry is actually a clinical social worker who works with Dr. Howard. And she really is a great representative and voice and advocate for the population who is being impacted through this work. Jennifer also has had I think some experience before starting in her healthcare position, working on suicide prevention with both middle and high school students, if I'm not mistaken. So really bringing that voice to the table and knowing kind of who is out there and how we need to message our work, once we get to hopefully the second cohort in the end of our work, helping us message some of this data that we're reviewing and getting that out to the right people and clinicians to know what they need to talk about with their patients. So Jennifer's been really good in supporting that conversation. And Diane McFarling, she's the director of one of our community mental health centers, and Beck is actually the one who connected us to Diane, and having that subject matter expert be there for us was perfect because he was able to say, hey, Diane is in an area that we were already seeing some trends around suicide, peaking around suicide and self-harm. And so he connected us with Diane, who is actually in that area and is director of the Community Mental Health Center. And not only that, but she's also a coalition member within their region as well. So they have a suicide prevention a regional suicide prevention coalition. So it was great to have that connection and know that we could work with both of these groups moving forward. So that's kind of where we are with rounding out our team and really being able to talk to them about how we can implement zero suicide in those clinical settings. And that's how their biggest role is for us. And I think I can go to the next slide. Thanks. So rounding out our understanding as a team of focusing on zero suicide and as the framework that we wanted to move forward with and what that looks like is in the real world clinical setting, using the guidance from our subject matter expert and our data and having those people in the areas that we want to focus on, we came up with the understanding of just assuring that we're really using our data to the fullest to determine all the gaps that we need to address moving forward. And whether that might be a gap in data or practices, we really wanted to be able to use our team members when we did find those gaps to be able to address some of those findings. So maybe looking at, for our subject matter expert, being able to support us in knowing which best practices to use in clinical settings and maybe what's been being done in other states, because Beck does have that information as well as, who's using this already and how can we use that in our clinical setting and having an understanding as a team moving forward and common mindset. We can go to the next slide. So our additional team members, these are kind of some of the people that we have in the background, but they are as important, not necessarily active on our calls and in every meeting, but they are so important to the work that we're doing in Kentucky. If you can look at some of those, you'll see that what they are providing are vital statistics, so getting our death certs and the conversations with the coroners around, what might have happened to adolescents who have died by suicide. Kiprick is our wonderful data holder for all things, and where we got our original data to start us off before Bethlehem actually put it into visuals. The KIP survey is wonderful. We get the fortunate opportunity to have that survey, which really talks about risky behaviors in high schoolers throughout the state, and that's administered, I think, every other year. So it really supports some of the work that we're doing as well. And then obviously the Center on Trauma and Children gives us that further support and guidance on maybe best next steps around clinical practices too. And I will turn it back to you.
Thank you so much, Nicole, for sharing with us how that team got rounded out, shared a vision together, had a shared understanding, and were able to move forward together. Very exciting team that you have assembled. So again, wanting to hear from you, and I've seen there's lots of great conversation happening in the chat. Jenny, thank you so much for helping us with that conversation. So I'm curious, how would you describe the involvement of your team in your quality improvement work? And what do you need to do to strengthen that team? So I saw some folks sharing, specifically I saw Brittany and Jeannie sharing in that chat a little bit about how their team's involved in their work and how you involve them. But also, what do you need to do to strengthen that team? I'd love to hear that as well. So I'm going to give you guys just a minute to type or really feel free. I know, Jeannie, you had some great things to share. So if you want to unmute and just share with us, we'd love to hear that. Andra says that they share information and chances for input, but have had difficulty getting feedback. Often that's difficult. You really are often dealing with very busy people. This might not be their top priority. So yeah, sometimes getting that feedback directly can be difficult. So being able to meet in person would be helpful. Obviously, we've all been locked in our houses. I'm sorry, I think I had an interruption in my audio there, but we've all been locked in our homes, and being able to meet in person would be so much more helpful. So I see a few more folks typing. Thank you so much for sharing time. So Brittany says, we have quarterly meetings where we share information, receive feedback, beginning to administer quarterly surveys to assess how we can best support our stakeholders. That's great, really focusing on that. And then, in Texas, I'm hearing that, involving other team members in the conversations for planning can be difficult. That often is difficult, especially folks who are outside of your organization. Sometimes that management sponsor can help you, or sometimes it's really that one of those key state partners. So I think there was a great example in Kentucky where their subject matter expert was able to involve a local partner by identifying them. So you're using your resources to getting folks involved. It's great. Okay, so I am so excited to kind of continue on thinking about this team, but also thinking about the role of leadership. So I want to just keep going
and think about, as the leader of this team, what do you need to have? And I want you to think again about those 5 principles and then look at these leadership skills that we're going to point out. And again, this comes out of that research from the University of Wisconsin. They looked deeply into what it was that made a successful project and what were the skills that the leaders of those successful projects had. And what those skills are is to be organized, persistent, innovative. If you're going to lead change, you have to be able to be innovative, right? Innovative in your thinking, but also innovative in how you're going to lead that team, how you're going to engage them and bring them in. The leader needs to be someone who's comfortable with data. I want to be clear, you don't have to be a data person, but being comfortable with data is incredibly important so that you can really think about where you're going, you're comfortable with looking at it and making decisions based on that. This is also someone who often really needs to be very focused, right? So someone who can really focus on the problem and also has time to focus. We want to be clear that this person needs to be someone who's not overburdened. This isn't something that's added to your plate on top of everything else. There needs to be some time to be focused on the project, to lead the project in all of these different ways. And someone who's optimistic. You're making a big change. You're changing things. You're trying to make improvements. So in order to make improvements, we have to believe that improvements are possible. So it's important for those folks to be optimistic. And sometimes, like in Kentucky, these skills might not all be in one person. So we may bring in have co-leaders. And so I want to turn it over to Kentucky to really talk a little bit about how they used a co-leadership model in their suicide and self-harm reduction work. So I'm going to turn that over to you all.
Okay, yes. And so I think having the co-lead model from the beginning is really what we felt was the best way moving forward. And I think Jan recognized that, and I think she saw the strengths in Nicole being the co-leader with me as well. And I think that is looking at your team and assessing what you can and cannot take on, especially with this last year and people being pulled in so many different directions. And so, our co-lead has really worked fabulously. And I think the importance is you have to be able to communicate with the co-lead. And the other thing I like is that it really helps you to hold each other accountable. And if anything, it's so easy for projects to keep getting pushed down the list. But when I have Nicole checking in and saying, hey, where are we on this? Or do you want to meet for this? It really helps this to stay in the forefront of our mind. And because we all get busy with projects, and I think that just having that accountability is huge. Time is important, and with us being stretched between multiple different projects, having the co-leads be able to devote the amount of time that's needed is important. And the other thing that I kind of like about us having the co-lead role is that Nicole and I are from 2 very different organizations. And so being from those organizations brings in a unique facet to each of the co-lead positions. And I think that having that helps. Nicole, did you want to add anything?
I think you covered it really well. And just, I think our personalities too just complement each other. And, we both have a different way of leading, but it works so well together and really has just helped us move forward with the work that we know has to get done. So it's been wonderful to have another person doing this with me.
It's so interesting.
Dr. Howard.
You guys are, in talking to you, I have to say you guys are such a dynamic team, and so it's so exciting to have you share your experiences here with so many folks. I have to say that, each thing that you talked about really gets back to those key leadership skills, that focus, the optimism, all of the things that you talked about, the persistence and innovation that you both bring in different ways. So thank you so much for sharing that. I'd love to hear about how you're doing that. So I want to move on to some time for Q&A. I think we have the really rich experience of our team from Kentucky who can share, or if you have any other questions about how teams work in the quality improvement setting, I want to open it up here for questions that you may have, and feel free to either unmute your line and share out loud so we can hear your voice, or type on in the chat if you have any questions.
This is Jenny. I have a question.
Yeah, go ahead.
I was just hearing, Dr. Howard and Nicole describe their co-leadership and the, really diverse team and so forth. I'm curious about any challenges that you experienced bringing together such a diverse group of organizations from state and hospital setting and so forth, and, how you managed those challenges of the different sorts of expectations that each of those organizational levels brings in, or working styles and so forth. How did you build team cohesion across that cross-sector partnership?
Yeah, and thank you for asking that. I do think bringing in a clinical component can be challenging in this day and age, and I say that because I think providers, and that's myself and then Jennifer as well, being an LCSW, have certain requirements from our employers regarding, how many patients we see, those types of things. And so it does help that we do have a contract with DPH that allows me to have some of that non-clinical time to work with them. And I think that has been a huge help in that accessibility to clinical providers. I don't feel like we've ever had a problem with anyone on our team not getting along. I think our passion and drive really overcomes that, because everybody on our team is very passionate about prevention of pediatric suicide and pediatrics just in general. And so I think that has really helped with a lot of our communication. And so we all get along great. We haven't really had anything that we've disagreed on horribly. And I think that that's part of who we've brought in on the team as well.
Thanks. It's often so difficult to pull together those teams of diverse folks, and especially there's always that challenge of billing when you're working with clinical folks. I appreciate you addressing that, Dr. Howard. Any other questions from our participants who'd like to either share your experience or ask a question of our presenters? Well, I am happy to let you know that all of these slides are available in the file pod above, so you can always grab those if you really need more time to digest this information before you can ask questions, although I do see some folks typing, so I'm going to give that just a minute. So if you have a question, or Rachel, you can just unmute your line and ask questions. Great. Wonderful. Well, I am so glad that we've had this opportunity to talk to Kentucky and ask these questions. And Rachel, if you have a question, we can go ahead and take that over the phone. You're on the Missouri team. I think that what helped us stay on the same page without face-to-face meetings, our group emails and working documents. Using that technology, thank you, Rachel, that's such a great point. Using some of that shared workspace technology that's available to us can be really helpful to make sure that people have access to what they need and so that they can do that work on their own time, right? So that's a great point, and thank you, Rachel, for sharing your experience. Okay. Wonderful. Yeah, in this day and age, we have to use all the tools that we have access to. So I'm going to go ahead and move forward because I have some things I'd like to share with you all. If there aren't any other questions, we'll just go ahead. And I just want to share with you, I'm not able to advance to the next slide. There we go. The CSN is always here to help, so you can check out our website for resources. If you need technical assistance, if you don't have a QI subject matter expert and you want to talk that through, you're always welcome. Use that link to request TA from us directly. Keep in touch about the Child Safety Learning Collaborative and join our newsletter. I'm excited to share with you guys that we are launching our cohort 3 of the Child Safety Learning Collaborative, and applications are available now. You can see up at the top there in the file pod, there's an application for new members. If you haven't been a part of it and you're thinking about joining, we really encourage you to do that. We have teams on poisoning prevention, bullying prevention, sudden unexpected infant death, suicide and self-harm, and motor vehicle traffic safety. So thinking about that, we'd love to see your applications. We also, if you have questions about how that's going, we have informational webinars available in advance of when those are due. So you can follow the links I think we're going to put a link. Oh, there it is. The link is already in the chat. Thank you, Kate, for our July 22nd informational webinar. And then we have another one on August 4th if you'd like to learn some more about the work, more about the CSLC participation in it and how you can complete an application. Moving on. We are going to be at the Safe States Conference. We're currently at the ongoing PrevCon conference that's happening right now, but we'll also be at Safe States Conference presenting on building health equity and pivoting our progress. You will see that we are launching right now into a short evaluation. We ask that you give us feedback because, like you, we are always trying to improve our work, and so your feedback does help us do that. So if you could just take a moment to do that feedback survey for us, we'd be so grateful. If you have any other questions, we will remain here on the line for another minute. Otherwise, I'm just so grateful for your participation and staying with us and listening to your colleagues about their great work and sharing your experiences. Thank you so much.